Lipids are always a challenge and always an interesting topic. The European Atherosclerosis Society recently released a landmark consensus statement on improving awareness of the need of early detection and management of children with familial hypercholesterolemia. And that was the impetus of a new study, and we're here to talk about that and actually two other studies too. I'm with Dr. and I'm hoping you get this right, Dr. Andrew Tershakovec, who is an MD and an MPH and the Executive Director of Clinical Research at Merck. The first one I want to talk about is, it kind of evolved from this, this consensus statement, estimated prevalence of possible and probable familial hypercholesterolemia in almost 36,000 statin-treated patients across a variety of countries, Europe, Canada, the Middle East, South Africa. First off, why did you do this study?
Well, the DYSIS study was done to evaluate the LDL cholesterol levels and get some sense of how many people in different countries around the world do have high levels, especially very high levels, and especially focusing on very high-risk patients. Patients with familial hypercholesterolemia have a specific genetic form of elevated cholesterol level and have been known for decades to be at very high risk of cardiovascular disease. Some of the patients with the worst forms of familial hypercholesterolemia will actually develop heart disease as teenagers or in their 20s. So it's an important factor to identify early so you can find these very high-risk patients. So by using the DYSIS data, the investigators were able to screen for people with the highest levels and get some sense of how many patients or people in these different countries may have unidentified familial hypercholesterolemia. And they found, these numbers aren't huge in a proportional percent. It's not like 50% of the population. It's a relatively small proportion of the population. But if you look around the world, it's tens of thousands of patients who are at very high risk that need to be identified and that do benefit when they get their cholesterol level lowered.
I think the data that they used in the consensus document was there's one child born every hour with this condition. So that is quite a few people.
Sure.
When you look at it across a broad swath of folks. Now, are they getting recognized, number one, are they getting treatment, number two?
Yeah, well, there are two different forms of familial hypercholesterolemia. So you have the people who inherit both genes and who have very, very high LDL levels, who may have LDL levels of 500. And those are the ones who can have heart disease as a child. But that's very, very rare. But the more common is called heterozygous familial hypercholesterolemia, where you just inherit one of the genes. And those are people who commonly will have LDL cholesterols of around 200. And those are largely unidentified, especially as young adults. They're frequently identified when they have a heart attack when they're 40 or 50 years of age for the first time.
So what did you learn from this?
Well, I think it's combining with the identification from these expert panels saying that we need to be more aware of these factors. And now that we have treatments, we have very effective treatments who can lower LDL cholesterol levels very aggressively in a relatively well-tolerated manner. And so I think it's important to spread the awareness of the problem, to have physicians start invest in identifying these patients so then they can treat them effectively and to decrease their risk.
Now, there were a couple of other DYSIS papers presented here at ACC 16. Can you talk about them for just a minute, DYSIS 1 and DYSIS 2? One persistent high distance to recommended LDL cholesterol targets despite chronic statin treatment.
Sure. So in that part of the DYSIS study, what they looked at are patients who were treated with LDL cholesterol lowering therapy, in this case specifically the statin drugs. And then they looked at what were their LDL cholesterol levels on treatment. Now, various treatment expert treatment panel groups, such as the European groups, have suggested targets or thresholds that you should get your LDL cholesterol level down to if you are patients with heart disease or if you're a patient who has other risk factors. And so this was looking at those patients based on the risk factors they have, how close they were and how well they were being treated. And what we're finding, this has been shown in DYSIS and lots of other surveys, is patients, while they're being treated, are not getting to the levels they should be. And so that means that their risk isn't being decreased as much as it could be.
And DYSIS 2, what are you looking at there?
Well, DYSIS 2, I think, is an extension looking at more countries and also they also focused on patients who had more recent heart attacks. So it's really just focusing on a higher risk type of patients. But the message is really kind of the same as, from all of that series. So we have these very high risk patients that we consider that may have familial hypercholesterolemia. They're not being identified. We also have patients who have heart disease and patients who have other risk factors that have been identified and are being treated, but we're finding they're not being treated well enough, that they're, for whatever reason, they're not getting their levels to where they should be, and that lowering their levels should decrease their risk.
Well, it's a major topic. I mean, like I said, the EAS estimates one child is born with familial hypercholesterolemia every minute, and that is it's definitely an issue that we need to think about more of. And there are now treatments that are pretty effective, but first you have to find them.
Yep, exactly.
That's get them to actually take the medicines.
Yep, yeah. Now, it's an important thing. I think it's identifying the patients, it's getting them on therapy, it's evaluating, is the treatment being as effective as it could be? Do you need to optimize the treatment in some way? And then also checking with patient compliance and taking it, because again, this is a lifelong problem. It's not something that you can take the medicine for 6 months and say, okay, now I'm going to stop.
Exactly. So for a variety of coverage from ACC 16, please check online and at CardioSource World News, where I'm Executive Editor Rick McGuire.